Let us begin with our first presenter, Dr. Rahela Ambara's Han. So Dr. Han obtained her PhD in evidence-based pharmacotherapy from the University of Malaya in 2018. She obtained her Board of Pharmacy Specialists in Pharmacotherapy certification from the US in 2013 and was recognized as a subject matter expert in ID by Ministry of Health Malaysia in 2021. Dr. Han is actively involved in various committees at the hospital, national and international levels. Additionally, she actively participates in ward care, including in the ICU, and she is actively engaged in antimicrobial stewardship rounds and vancomycin rounds.
Thank you, Dr. Hafiz, for the kind introduction. Assalamualaikum and very good afternoon from Malaysia. First of all, I'd like to thank the organizer for inviting me to share regarding antimicrobial stewardship in Malaysia. Okay, so this is the outline of my presentation. I'll be touching on AMS in Malaysia and the challenges that we are having. To start with, I just wanted to share this National Health and Mobility Survey in 2020. So basically from this survey, what we found is that majority of the population in Malaysia, we got antibiotic from correct source. However, the awareness of antibiotic resistance is still low because in Malaysia, antibiotic is actually a prescription drug. So you cannot just buy antibiotic from a retail pharmacy. You need to get prescription. So somehow we have some control in terms of that. But in terms of awareness of AMR is still lacking. That's why we are here. So basically, the answer is antimicrobial stewardship, whereby from this stewardship, we can actually optimize the use of antibiotic at the same time to minimize or avoid side effects and also resistance. From this paper, it concludes that by conducting by conducting antimicrobial stewardship, it appeared to be effective in reducing antibiotic consumption in both hospital and non-hospital setting. And that's why we need to advocate on antimicrobial stewardship. I go through the core element for antimicrobial stewardship that we need to emphasize. It includes leadership, commitment, accountability, expert. At the same time, we need to have action, for example, the intervention, prospective audit, feedback, and whatnot. Monitor the initiative that we conducted, do the reporting, and also education. So let's see the element highlighted by IDSA in this paper. So basically, they are the same, just a few things that, they added. For example, in terms of education alone, we cannot just rely on education alone. We need to have other initiatives as well. We need to have facility-specific guideline to standardize prescribing practice based on local epidemiology. Prescriber-led AMS review. We cannot just rely on ID physician to conduct AMS review. So everybody need to be responsible towards their prescription. AMS microbiology lab. So it's good to have stratified antibiogram to optimize the therapy, and need to have selective reporting, whereby if let's say the organism is sensitive to narrow spectrum antibiotic, then they hide the broad spectrum antibiotic. With that, we basically can control the usage of broad spectrum antibiotic. PKPD-based dosing and shorter duration of therapy. So for PKPD-based dosing, for example, if you wanted to do extended infusion or continuous infusion, we need to settle the issue, for example, the nursing time, education towards pharmacy, and also for patient to have dedicated line and whatnot. For duration of therapy, what they advocates when we prescribe antibiotic, we need to have duration at the same time so that we can minimize the unnecessary continuation of antibiotic. Okay, let's see what we have in Malaysia. Basically, is in relation to the papers that I mentioned to you just now from the CDC and from IDSA. So this is the AMR journey in Malaysia. As I mentioned earlier, leadership is very important. That's why we have the formation of National Infection Control and Antibiotic Committee meeting at the national level in 2001. In this meeting, we discuss about national surveillance on antibiotic resistance, about alert organism, about utilization of antibiotic, and try to come up with the initiative how to improve. We also have National Antibiotic Guideline in 2008, our first edition. It's not easy to come out with a national guideline, but we managed to do it. And this year will be the fourth edition of National Antibiotic Guideline. We also have the Act for Medicated Feed, yeah, for the animal health. We have the protocol for AMS at healthcare facility. So this is actually was published in 2014. What basically we emphasize in this guideline is towards the formation of AMS committee and also AMS round on top of other initiatives. From 2015 onwards, we actually focus on Malaysian Action Plan on Antimicrobial Resistance. So we have from 2017 to 2021 and also currently 2022 to 2026. So we have about 4 TWG, the Technical Working Group. I'll be touching on this on the next slide. On top of that, for the animal health, in 2021, we managed to come up with the National Veterinary Antibiotic Guideline to guide on the selection. Okay, so this is what I mentioned just now, the technical working group. So we have the initiative, for example, awareness and education, surveillance and research, infection prevention and control, appropriate use of antimicrobial. And our outcome indicators that I wanted to highlight is basically increased level of awareness, knowledge, and understandings of AMR, 5% reduction in antibiotic use in animal sector, 30% of critically important antimicrobial for human and veterinary medicine not to use as a medicated feed. So I think previous years in our first national action plan, Malaysia banned the use of polymyxin as medicated feed in animal health. And also for the treatment because our hospitals still use polymyxin as a last resort for multi-drug resistant organism. At the same time, we also put inside outcome indicator at least 60% of overall of antibiotic consumption coming from the access group. Yeah, so we know the aware classification. So we hope to have like more antibiotic coming from this group rather than watch and also the reserve group. Last but not least, 30% reduction in hospital-acquired bloodstream infection due to selected MDRO. So the problem in Malaysia are acinato, CRE, and also basically the third one, Pseudomonas aeruginosa. But the common one are basically acinato and also CRE. Okay, under Malaysia National Medicine Policy, things that we did to, in terms of AMS, the first one is actually establish accredited AMS training center. Currently, we have 2. This year, we already, certify one more training center at the East Coast, Kelantan, as a AMS training center. Monitoring and surveillance of antibiotic, we try to increase participation of private hospital in giving their antibiotic utilization. Last but not least, provide the public with accurate and relevant information on AMR. So we will continue doing the education and awareness to public as well. Okay, so this is what I mentioned just now about antimicrobial surveillance in Malaysia, the utilization. So our pharmaceutical services program at the Ministry of Health, they collect utilization of 18 antibiotic from Ministry of Health Hospital, Ministry of Education, private hospital, Ministry of Defense. So this data include data from all ward and also ICU. So we will tabulate the data and try to come up with the initiative how to improve. So this data actually being presented at National Infection Control and Antibiotic Committee meeting chaired by our Director General of Health. How about at facility level? So data to the ministry, we send 6 monthly. Now already like one year we will send yearly data to ministry. But at our facility level, some of us do monthly monitoring and some did like third monthly monitoring. So for my hospital, it's monthly monitoring. How we disseminate the data is through WhatsApp group. Okay. That's the easiest for us. Yeah, we have the HKL antibiotic surveillance WhatsApp group. So the data will be sent there. And we know the prescriber, they don't like to see the data much. So we try to summarize what is the important message for that particular month. Yeah. Every 6 months, we also provide the report in terms of antibiotic utilization and we compare from one discipline to another. On top of utilization, we also have the consumption data. Basically, this data being expressed through DDD per 1,000 inhabitants per year. So the latest one is 2017. The 2018 to 2022 will be published this year. Yeah. So from there, everybody can see, about our utilization, not just for anti-infective, but also other drugs. Okay, next initiatives is pre-authorization form as being advocates by the CDC and IDSA. So pre-authorization form, we don't have anything coming from ministry. Basically, it's a facility initiative. So in my hospital, we have a few drugs that need pre-authorization form, for example, carbapenem, polymyxin, and vancomycin. So the prescriber need to send Part A form. When they wanted to continue as empiric antibiotic, then they need to send Part B. If let's say the antibiotic is definitive therapy, then Part B is actually exempted. This is very good initiative because from this data, we know that what is the most empiric antibiotic being used. Like in my hospital, meropenem is the most empirical antibiotic. That's why we continue with, focusing on carbapenem rounds rather than general antibiotic round, because we know most used empirical antibiotic is actually carbapenem. Because of a few hospitals conducted this pre-authorization form, some monitor the data, some don't monitor the data. So for those who doesn't monitor, they feel extra burden. But for those who monitor, we feel that, this is very good initiative and we can get something out of it to improve antibiotic utilization in our hospital. For example, the one that conducted this, Hospital Sungai Buloh and also Hospital Kuala Lumpur, we found that carbapenem usage reduced after we implement the pre-authorization form and also stop order. Due to that, our Director General of Health agreed to expand this to all Ministry of Health hospital to do carbapenem 72-hour stop order and review order this year. So everybody has to do it. Okay, next will be formation of AMS team, to conduct AMS rounds. So this comprised of ID physician, microbiologist, pharmacist, and infection control nurse. So this is the form. Some hospital, they are IT hospital, but some are manual, like my hospital still manual. So we have to do everything manual. It's not easy, but we try to do the best that we can do. And we also tag the notes, the ID notes, the AMS note, we will tag with this sticker so that easier for the primary physician to see what's our plan. Type of recommendation, most of the time, de-escalate to narrow spectrum antibiotic, dosing adjustment, duration adjustment, and also discontinue current antibiotic. Okay, this is the initiative started in my hospital because we found that the ID physician, not many, okay? Most of the time, they can only cater AMS round at medical department. So basically, we have a team from nephrology and urology department, urology and neurosurgical, ICU, and also surgical ortho. We nominate them officially from our director of hospital, giving them the training and giving them the form and asking them to do at least twice a month antibiotic round. So for some department like ICU, they do weekly. So from this, they also excited to see their own prescription and, discuss whether can this de-escalate or escalate or cut down the duration. And now I think become a norm in this hospital, but some departments still didn't do much. So how we actually overcome this is through the discussion with them. So our ID physician sit down with them and discuss to see what's their limitation and try to help them in terms of conducting their own department-initiated MS round. Okay, other than that, we have a facility stratified antibiogram. It's not easy to come up with this, but of course, when you have this stratified antibiogram, actually it helps a lot. So we have in our hospital, for example, bloodstream infection, respiratory infection, and urinary tract infection. On top of that, this is the national initiative, point prevalence survey on antibiotic at MOH facility. So not just to hospital, but also to primary care. We conduct yearly. For hospital, we wanted to see prevalence of patients on antibiotic, prescribing behavior and compliance to guideline. And for primary care, basically for pattern and prevalence of antibiotic prescribing in health clinic. So the data from our own hospital, we analyze. We don't just wait for the, the national data. We analyze and we disseminate to our HOD. So most of the time, most hospital, their prevalence is about 40 to 50%, the patients on antibiotic. Okay, IV to PO conversion. Every hospital, they have their own initiatives. Some come up with the flyers, some come up with the podcast. So we hope with this we can actually advocate in terms of more conversion of IV to PO switch, because when we conducted point prevalence survey, we found that this strategy not everybody actually implement. That's why we come up with the initiative to improve it. Okay, how about AMS in private hospital? So all the initiative that I mentioned, mostly at public hospital and also university hospital. So private, what they have utilization. So the move that we try to push them is actually what our head of program for ID, he tried to incorporate AMS inside the hospital accreditation program under MSQH. So it is like a push factor for them to form a committee, a hospital infection and antibiotic control committee, and then educate their staff in terms of AMS and come up with the initiative for AMS. We also receive these pharmacists from the private hospital coming to our training center, Sungai Buloh and Kuala Lumpur Hospital, to be attached for AMS. Last year, we even have one trainee coming from Netherlands to be attached at our hospital for AMS training. The component inside the training that I wanted to highlight is like the case clerking, not just in medical ward, in various ward. We have the ID clinic visit or pet center visit. We have vancomycin round. Maybe you wonder why vancomycin round, because our AMS round doesn't include vancomycin. Most of the time, we found that vancomycin is being used as definitive therapy, but our challenges is towards the dosing. So that's why AMS pharmacists together with TDM pharmacists, they went to see the patient together to see the suitability of changing. For example, if let's say you see some patient doesn't get level for 1 month, so we try to improve in terms of changing the drug, or case like, for example, not appropriate use of vancomycin, so we try to alert our ID team to come and review the patient. That's why we have this vancomycin in our hospital. We also have visit to allergy clinic and visit to microbe lab. So we have immunologists here. So our trainee managed to see how allergy testing being conducted. Okay, so in Malaysia, we have credentialing for AMS, yeah. Previously, just for public, for pharmacists from public Ministry of Health hospital. But now we try to discuss with our board of pharmacy and try to expand to private hospital as well, so they can be credentialed for AMS. Okay, other than that, we also have subject matter expert in infectious diseases recognition for our pharmacists. However, it has been stopped last year. They wanted to review back, not just for the pharmacy side, but also all the subject matter expert in public service. So due to that, we try to do a different pathway for our pharmacy. I just came back from the meeting to do module for Malaysian Advanced Clinical Pharmacy Program. So AMS is one of it. We try to recognize our pharmacists, the senior pharmacists in AMS, yeah, for them to get some recognition, because we don't have the subject matter expert anymore. Okay, this is national guideline. We have National Antibiotic Guideline General, the top one. The 2024 will be launched this year. And we also have guide to antibiotic therapy in adult ICU. This one, the initiative from Malaysian Society of Intensive Care and also Ministry of Health Malaysia. So most of the ICU, they will follow the guide to antimicrobial therapy in the ICU. I have also mentioned earlier about the antibiotic guideline in veterinary side as being shown on the slide. Okay, this is the education on antibiotic through mass media, yeah, and also antimicrobial resistant awareness week. This is the time that we do education to our healthcare professional and also public. And we have many interesting program as well. For example, structured basis AMS for our house pharmacists, housemen, yeah, for them to understand about antibiotic and also antimicrobial resistance. We have other activity as well. For example, daily poster, roadshow during AMR Awareness Week. Yeah, booth visit where we also bully our director to put the right antibiotic for the right group. But she managed to do it. Okay, other than that, we try to do something fun. For example, AMS game-based learning, it will be conducted June. Yeah, for them to have some fun while they're learning about antibiotic. We also have OPED, but not very advanced. So some some have like drug that you can be given as continuous infusion through the elastomeric pump. Some still just, focusing on once daily dosing drug to be offered for OPED. And we also quite active in terms of antibiotic research. Okay, this is the national initiative. This year, we will start in all Ministry of Health hospital, the surgical antibiotic audit. So the guideline has been endorsed by our DG. So everybody has to do it this year. So are we doing enough? I'll go very fast. I'm so sorry. So basically what I wanted to highlight here, if you see human health, we are among the level of demonstrated and sustained as compared to the global, okay? Animal health, some still under limited. Food and agriculture within demonstrated and sustained, and environment something to be improved. Okay, challenges for MS, I go very quickly. This is from the paper for LMIC country. So basically they are the same. Facilitators is relevant to us as well in terms of availability of guideline, dedicated team, pro-microbiology lab, yeah, reserve antimicrobial list, so very relevant to us. And the barrier also almost the same. For example, lack of human resource, lack of leadership, something that we have to improve. So this is a local paper. From pharmacy side, what we found, the barrier is actually resources and attitude. So for the resources, they feel that talks is not enough. They want attachment. So this paper published 2019, that time we don't have accredited center for AMS. Now we already have, because sometimes when you learn from talk, you feel that everything is easy. But when you see the patient, the patient got allergy, pregnancy patient, all that. So things become very complicated. So they appreciate attachment where we already have it now. And insufficient full-time AMS pharmacists, ID physician specialists, as well as time constraint. I think everywhere the problem is the same. So we try to improve it from time to time. So conclusion, many strategies are assisted by AMS in promoting judicious use of antibiotic. So hospital may adopt the most feasible stewardship strategies, yeah, for their facility. And AMS team formation is fully encouraged. So this is my last slide just to show this is the Committee of Pharmacy at ministry level. And this is basically, the photo that we took after the discussion of National Antibiotic Guideline with our ID and also microbe. This is the AMS committee in my hospital, which inclusive of ID, pharmacists, microbe, and also nursing side. And this is all pharmacists in my hospital that try to facilitate all antibiotic initiative in this hospital. With that, thank you.
Thank you, Dr. Rahela, for that great and insightful talk. So if you have any questions, please hold them because we are going to have another session at the end of this meeting where we can ask our panel of experts and discuss if you have any questions on any of the topics.